Hello, my name is Terry Lake, and as many of you know, I'm the new CEO for the BC Care Providers Association. I'd like to welcome all of the viewers here today for the first day of the BC Care Providers Association conference entitled COVID-19, What Set BC Apart? As part of this particular session titled Seniors Care and the COVID-19 Pandemic, How the International Community Has Responded, we will talk further about some of the international experiences from COVID-19 and its effects on seniors care, including from Canadian expert Dr. Samir Sinha, as well as across the world, such as Dr. David Grabowski from the United States and Professor Li-Fei Lo from Australia. Before providing some background information and introducing our guests for this session, however, I would like to start off by thanking our sponsor for this event, Essity. Without our sponsors, it would be very difficult to provide this conference today. In March 2020, the COVID-19 pandemic was declared by the World Health Organization. To date, most countries across the world have been affected to some degree by the pandemic. Along with workers particularly hard hit have been seniors, including those living in long-term care, where most seniors are already increasingly frail and often suffering from multiple chronic conditions. To protect such vulnerable populations, jurisdictions in Canada and across the world have taken various approaches to prevent and reduce the spread of COVID-19, such as the increased use of personal protective equipment and by limiting those who can visit or even work at multiple senior care homes. The long-term care sector in Canada and abroad has been particularly hard hit by the COVID-19 virus, accounting in some countries for the majority of COVID-19 related fatalities. In late June, for example, the Canadian Institute for Health Information issued a report showing that long-term care residents made up about 80% of all reported COVID-19 deaths nationwide, in contrast to an average of just 42% among all other countries studied, including at that time approximately 30% for both the United States and Australia. While Canada has been relatively successful compared to other jurisdictions in limiting the overall spread in the community, we have seen thousands of COVID-19 related deaths occur in long-term care settings. Although each jurisdiction has been affected to some degree, various provinces, however, have been affected differently, which will also be the focus of our panel discussion tomorrow with various experts across Canada, including Michael Nyssen, Executive Director for the National Institute of Aging at Ryerson University, who will act as moderator. Along with the World Health Organization, the International Long-Term Care Policy Network has published various reports outlining different COVID-19 responses from various countries. In June 2020, for example, it released a major review highlighting that COVID-19 rates were between 0 and 72% among residents and between 2% and 64% among staff in long-term care homes. Today, as part of this discussion, we will be interviewing several experts to get their perspectives. First, we will interview Dr. Samir Sinha, who is a passionate and respected advocate for the needs of older adults. Dr. Sinha currently serves as the Director of Geriatrics of the Sinai Health System and the University Health Network in Toronto, and is the Director of Health Policy Research at the National Institute on Aging at Ryerson University. Also providing some background of the work from the National Institute on Aging, Dr. Sinha will discuss how Canada and various provinces have responded to COVID-19 in the context of seniors' care. Likewise, he will also discuss how we can better prepare for any potential future waves, as well as what the federal government role should be. After Dr. Sinha, we will interview Dr. David Grabowski from the United States, which has been particularly hard hit from COVID-19, with over 6 million confirmed cases and now close to 200,000 deaths. COVID-19 has also had a terrible toll on that nation's 2.5 million nursing home residents and their families, resulting in more than 50,000 resident deaths. People living in nursing homes make up less than 1% of the U.S. population, yet account for up to 40% of all COVID-19 deaths in the United States. Dr. Grabowski is a professor of healthcare policy in the Department of Healthcare Policy at Harvard Medical School. His research examines the economics of aging, with a particular interest in the areas of long-term care and post-acute care. Likewise, Dr. Grabowski has been involved in a number of recent studies looking at contributing factors for COVID-19 outbreaks in the nation's nursing homes. Along with providing an overview of the United States long-term or nursing home sector, Dr. Grabowski will discuss how the federal and state governments have responded to COVID-19 in seniors' care, as well as some of his most recent research. Finally, we will talk with Li-Fei Loh, who, along with being an associate professor in aging and health at the University of Sydney in Australia, is a registered psychologist with a PhD in psychiatric epidemiology. Her main areas of expertise are in-home and residential care for older people, well-being in people with dementia, risk factors for dementia, dementia literacy, and also the impact on people from culturally and linguistically diverse backgrounds. As Li-Fei will discuss, Australia represents an interesting case study. During its first pandemic wave, Australia was overall quite successful in reducing both community spread of COVID-19, but also limiting outbreaks in long-term care. Unfortunately, the situation, however, has somewhat changed as part of the second wave, where Australia is seeing greater outbreaks in long-term care, particularly in Melbourne and in the state or territory of Victoria. As of mid-June, Australia had about 4 deaths per million residents in long-term care, compared to more than 212 in Canada. At the time, Canada's death toll in long-term care was over 6,000, compared to only about 30, according to the Australian Public Health data. At the beginning of September, when its federal government announced over $500 million in new funding to its aged care sector to combat COVID-19, the state of Victoria had reported a cumulative total of about 4,000 cases in residential aged care. Along with providing an overview of Australia's aged care sector, including some of its experiences faced during the COVID-19 pandemic, Professor Li-Fei Loh will discuss some background on its Royal Commission on Aged Care, which for over a year now has been looking at the current state and future of seniors or aged care in that country. I'd like now to start off today's discussion by introducing our first speaker, Dr. Samir Sinha, who, as mentioned, currently serves as the Director of Geriatrics at the Sinai Health System and the University Health Network in Toronto, and is the Director of Health Policy Research at the National Institute of Aging at Ryerson University. Dr. Sinha, welcome to the BC Care Providers Conference. You're part of an organization called the National Institute on Aging, which, along with a long-term care COVID-19 tracker map, develops reports on providing guidance on protecting older Canadians in long-term care settings. Could you talk about some of that work, particularly as it relates to this concept of the iron ring and what that entails?
Yeah, well, a lot of the work that we've been doing at the NIA related to long-term care really started last year. So the year before COVID hit us, we started really doing a deep analysis because there had not really been a comprehensive view on really long-term care when you think about nursing homes, retirement homes, when you think about home care, and how do we think about better caring for um, uh, our population as we age. And so a lot of that work that we did back in the fall really actually helped us to really help understand what the status of long-term care was in Canada, where the challenges, but also where the opportunities were. And also it helped give us a horizon of what the next 30 years will look like. Noting, for example, that currently we spend about $22 billion on long-term care, whether that be home care or care in nursing and retirement homes that are publicly funded. And we know that that cost will increase to 71 billion by 2050 if we just keep doing the same things we're doing today. So it really gives us a window on the future, but then you layer on COVID and you realize that lessons from SARS and other challenges, outbreaks that are not foreign concepts to care homes across the country. COVID-19 was a different beast. And as it started to hit the first homes in BC and then spread across the country, we really started seeing that every province was approaching the way it supported its homes a bit differently. We saw that a lot of guidance that was being considered was being implemented at different levels and at different time points. And so really the NIA decided that we could use our knowledge of long-term care, but also our healthcare expertise to really support care homes with, with clear guidance that the evidence that we also had access to would tell us of what we could do. And that came up with this term. So the term that was being used early on in Ontario was that of an iron ring: protect the homes, do what we can. And really, we said, well, what is the right formula for an iron ring? And a lot of it really was reflecting on a lot of the guidance that BC had actually been implementing right at the same time as we were issuing our guidance. It was the idea of recognizing that COVID-19 is not like influenza. It can spread asymptomatically and pre-symptomatically. That wearing masks and having everybody wearing masks is actually good policy and practice, but also thinking about enabling people to work only in one home, and also creating flexible admission and discharge policies. That was kind of the iron ring guidance that we'd released back on March 27th, around the time that BC had actually started implementing most of its key guidance that really protected its homes. But really, what we'd see across Ontario and other provinces across the country was that some jurisdictions like Alberta next door took upwards of a month to implement the same things that BC was doing. And through the other work that we were doing by tracking every single outbreak across the country with our tracker, and then by working further to actually develop guidance around how do we reopen homes safely and welcome back visitors and family caregivers. This is just a lot of the work that we've been trying to do to support our care homes across the country, and including in BC, to really help navigate a real tricky pandemic.
Now, you're a leading expert in geriatric care in Canada. People look to you for this type of guidance. And early on in the pandemic, you were quite critical of the situation in long term care homes, even advising families to consider taking their loved ones out of those settings. Has your opinion changed at all, or can you sort of talk about the evolution of the situation in long-term care homes and maybe the difference between what was occurring in provinces like Quebec and Ontario versus other provinces like BC?
Yeah, I think the first thing we have to recognize is that, in a fast moving pandemic, every single day counts and actions speak louder than words. And I think a lot of us have been seeing kind of the stories as they evolve in every province. BC has been held up, and I still think is an absolute leader, as a province in terms of its COVID response. So the view from BC is kind of like, well, we got things under control pretty quickly. We implemented guidance, our long-term care system didn't collapse, and frankly, we continue to have confidence in it right throughout. And honestly, if I had a loved one in a care home in BC, I'd feel very confident with what the response was and the actions that were being taken, because there was great leadership and a real committed group and a well supported group. But when you start looking at what was happening in other provinces across the province, across the country, we didn't start seeing kind of a similar level of support. Access to PPE, for example, was quite lacking in a number of other provinces. Making sure that we had supports in place to support staffing, and those sorts of mechanisms. And so, what you really started seeing was, with a lack of support to those sectors, especially in provinces like Ontario and Quebec, you will have seen that where in BC only 12% of homes ended up in outbreak. We're talking about 35% of homes in Ontario, close to 30% of homes in Quebec. We're talking hundreds and hundreds of homes that ended up in outbreak, and the majority of our long-term care deaths ended in these two provinces in particular. And right now, I think going into the fall, I personally am not confident that we've done enough to support our care homes in Ontario in particular to make me feel confident that if another major wave occurs, that they will have all the supports they need to really avoid having more challenges, as they face as we face the pandemic. And so, yes, when I was quoted by Andre Picard in the Globe and Mail saying, if my mom was in long term care, I'd pull her out, I stand by those words, because I was really concerned with what was happening, particularly in Ontario and Quebec. And while a lot of people at the beginning thought that, Dr. Sinha, you're being a bit alarmist, you're trying to grab a headline here. Well, I made that quote at a time when there were only a few hundred people dead in our long term care homes across the country. I don't stand here with pride saying that we've had over 7,000 people die in our homes, and that Canada in particular stands out head and shoulders amongst the OECD countries, with 80% of its deaths occurring in its care homes, which is double the international average. So while we can celebrate a lot of good work that we did beyond our long term care homes in Canada to stem the spread of COVID 19, we, especially in certain provinces like Ontario and Quebec and Nova Scotia and Alberta, we didn't fare as well. And we're still seeing the consequences of that today when we haven't put everything in place. So it really brings to light, and I'm still campaigning that we need more support for these homes. We have to recognize that these lives are important, that the people working in these homes are important, that the operators really want to do the best they can, and we need to do everything we can to realistically support them the way other countries and some provinces in particular, like BC, have done a particularly good job in showing that that's what needs to be done.
And noting the differences from province to province and the impact on seniors in long term care, is there a greater role for the federal government to play when it comes to a strategy for caring for seniors in Canada?
Yeah, I think a lot of people have been, been putting out a lot of statements, that we need to have the federal government's involvement, because we have to remember that long-term care remains the largest form of hands-on care that's been excluded from our Canada Health Act. So hospitals and physician services, those have always been as part of our original Medical Care Act of 1966. But even back in 1984, when we created the Canada Health Act, my association, the Canadian Medical Association, was begging to make sure that this not be excluded, but it was. And so the people say, well, maybe we should nationalize all homes. We should bring it under the Canada Health Act, for example. But I don't necessarily know if that's really the right answer, because yes, you could create a new law. You could say this is under the Canada Health Act. But what really achieves good quality long term care is when we appropriately fund it. Canada spends 30% less on providing long term care to its citizens compared to the average industrialized OECD country. 30% less. If you frankly just improve the funding situation when it comes to long term care, if we started to make sure that we had some common national standards, for example, that doesn't necessarily need legislation to occur. But what it requires is funding and a commitment to actually hold ourselves up to some standards and make sure that we can try and ensure that we're meeting those standards. I think we go a long way. So when people say, well, what should the federal government's involvement be? Certainly, it could be by providing more funding. It could be by convening our provinces and territorial partners together to say what should be those common standards that we want to achieve together for Canadians who need this type of care, and how do we best provide it, and how do we share information. So, do I think there's a role for the federal government? Absolutely. Do I think simply just nationalizing or bringing things into the Canada Health Act will solve our problems? Not really, because our problems are deeper than that. They really revolve around funding, and they really revolve around having a common national vision for really the care that we think that older Canadians, deserve and should get.
You mentioned that Canada doesn't fare well compared to other countries. I think in the US, Australia, for instance, 30 to 40% of deaths occurred in long term care versus 80% in Canada. Aside from the funding issue, you mentioned 30% less on long term care in Canada as a percentage of GDP. Are there other things that other countries are doing that have improved the situation for them versus Canada?
Yeah, so I think when you think about COVID in particular, we saw that countries that have done fairly well or much better than we did, when you look in Germany or Denmark or other countries, they specifically put more resources at the very beginning towards their long-term care homes. They recognize that these are homes that are housing incredibly vulnerable individuals. And so they actually put extra staffing in place. They actually made sure that these homes actually were prioritized for PPE, not put behind the queue behind hospitals and other parts of the system earlier. And so when you think about those targeted responses and making sure that these homes were well staffed and they had the supplies and the supports they needed, including extra supports around infection prevention and control, uh, these are the things that really were the recipes for the most high performing countries when it came to COVID-19 long-term care deaths. We know that that wasn't really the priority in many provinces that were hard hit across the country, and so these are some examples. But we also know that countries that have really leading long-term care systems, they're ones that have actually thought about the funding issue. So some countries around the world have really proactively said, look, if we know that our long-term care costs are going to triple from 22 to 71 billion over the next 30 years, we probably need to find sustainable funding solutions, especially when it's hard to understand who might actually need to be living in a nursing or retirement home, who might need to get home care, for example. So this is where some countries have created models of funding that are based on a social insurance model or a long-term care insurance model, that's a universal system, kind of like our Canada pension plan, but a system that it makes sure that those who need care will be able to get it, and frankly, as a country, will be able to afford it collectively. And other countries have really worked hard at also making sure that we're figuring out what's the right mix of services that we need, because we know that in Ontario, a day of care in one of our long-term care homes is about $183 per day. But a day of home care for a high needs individual who'd be, for our top 5% of home care users is about $103 a day. And reminding ourselves that when you don't have to think about infrastructure costs, when you can think about creative ways in which we galvanize the community together, sometimes it's not that we will never need care in care home settings. We always will need that, but it allows us to really focus on making sure we're providing the right care in the right place at the right time, and in a way that's actually in line with what people want. And really then focusing to make sure that the care we're providing in homes is high quality and well supported, especially for people who have significant behavioral issues or other things that really require them sometimes to be in a congregate living setting. But again, we really underfunded a system, and it really makes it tough for providers in every province across the country to build, the quality of homes that we know need to be built, and provide the quality of care, whether it be in a home or in a community setting that needs to exist as well. And so when you cut corners or do things on the cheap, you end up getting kind of the results that we've seen so drastically during this pandemic.
One of the underappreciated parts of the team in long term care are the family caregivers. And I think COVID 19 has really sort of demonstrated that once they are taken out of the situation, how devastating an impact that has on frontline workers and, of course, the loved ones that they're looking after in hospital. You've advocated for training family caregivers in infection control, and can you talk a little bit about that as a means of reintroducing family caregivers back into long-term care settings?
Absolutely. I think one of the things are we do a really good job. We have cross-country comparisons to say how many hours of care per person are being provided in a home, and that's by paid care providers, whether it be a what we call in Ontario a personal support worker, for example, a nurse, or, et cetera. But what we don't really do is we never really have quantified how much unpaid family caregiver time or friends and that sort of care is being provided in the homes. And I know that for many of my patients, when they transition to a long-term care home, for example, often their families don't stop caring for them. In fact, they just transition. Instead of doing all the care in their own private home, they're now sometimes spending multiple times a day or several hours a day in the home, helping with bathing or feeding or just companionship. And when we shut the doors, like most other experts, said at the beginning, with this fast moving pandemic, absolutely, let's limit foot traffic. Let's get the community spread issues under control so that we can limit the introduction by staff members and visitors into homes. I think all of us thought that, let's do this. But as this has now been 6 months in which some homes across the country remain closed, we've really seen how this has actually affected residents, especially when they don't have access, the usual type of access they've had to family caregivers who helped with important care tasks or just even from a socialization standpoint. And so, what we've really done is through the NIA, we recognized how all of a sudden, there was a greater risk of people dying from depression and loneliness and other issues than it was from COVID-19 in many homes. And so, by focusing on this, and there's now a lot of literature coming out to show that this, in fact, is true and this is the case, and that a lack of care from unavailable family caregivers means that this is more burdensome on staff, especially when homes, especially in Quebec and Ontario, have lost a lot of staff and they don't have them there. So our real focus has been on really kind of identifying the fact that family caregivers exist. They very much want to be a part of the care team. That frankly, I would often trust a family member to believe that they're probably going to do the best they can to try and make sure their loved one doesn't get COVID. I'm sure they would happily learn IPAC procedures. I'm sure they would happily don PPE and make sure that they're keeping their loved ones safe above all else. And so we've seen that in the Netherlands. We've seen in Quebec, for example, where Quebec had lost 10,000 frontline workers. And so they were frankly hoping that family caregivers would come in and fill in the gaps in care. But where we've seen in other jurisdictions where they've welcomed them back and they've actually made sure that they're trained and supported just like staff, we found that we can really support residents to get the best quality of care possible. That's why we released our guidance in July on how to safely reopen homes, thinking about the roles of general visitors, but also family caregivers in particular. We were proud to see that Prince Edward Island implemented our new recommendations almost immediately, and Ontario only in September, I guess, it could have been longer, I guess, has fully implemented our NIA guidance. And we're really happy to see that that's served as guidance supported by experts in infection control, caregivers themselves, who could actually participate in creating guidance that we say really finds that right balance so that people can get the care they need while also being kept as safe as possible.
And before we let you go, are there things we've learned over the last 6 months that will make the situation in long-term care better? I'm thinking about, we can have really deadly flu seasons in long-term care. Have what we learned, will we see some benefits in the future protecting seniors in long-term care?
I think we probably sadly learned, after over 7,000 Canadians have died in these settings, as well as over 16 staff as well, that we can't take our long term care homes for granted. That we sadly made choices in our country to better support our hospitals over our care homes, whether they be retirement homes or nursing homes. We made those choices, and we've now seen the consequences of that. I think now with the retrospectoscope, we probably would say, yeah, we should probably have made sure they had access to PPE. We probably should have done things like BC did and implement those key policies and the evidence that we had in front of us earlier. And that we shouldn't have really treated our long term care workers and those residents and their families as second class citizens. I really believe we did. I think we've now paid a painful price. We've learned a lot of lessons. And I think now that we have PPE, now that we know the value of IPAC, I think we're starting to recognize that we probably, if a home was to go an outbreak, we probably shouldn't be shutting out caregivers, family caregivers altogether. So we've learned a lot of things. I'm just hoping that we are continuing to strengthen the system so that if we were to have a second wave, not just a second ripple, as Dr. Bonnie Henry has been calling it, but if we do encounter a second wave, that we will have far better results because we are now learning not to take the sector for granted, to make sure it has the appropriate supports in place, and that we really do have a true system response should these residents and their families and these frontline workers need it. So I'm more hopeful that we won't relive the carnage we did through the first wave. But I feel that honestly, at this point, some provinces are better prepared for a second wave than others. I think BC's in that camp. I don't think Ontario and Quebec are firmly have everything they need yet. And I'm going to keep advocating because, frankly, I have lots of patients who are living in care homes. It's the best place for them to be. but I don't want anybody to regret either choosing a career in these homes, or choosing to have their loved ones in these homes, or residents for feeling guilty for being in these homes. I think we as a country have a duty to support those people working, living, and those who have family members in these settings. And I think if we do that well, then we can hold ourselves, we can hold our heads up high, knowing that we're doing the best we can and that we have done the best we can.
Dr. Sinha, thank you very much for your insights today, and thank you for your continued advocacy on the part of senior Canadians each and every day. Thank you.
Thank you very much, Terry.
Our next speaker is Dr. David Grabowski, a professor of healthcare policy in the Department of Healthcare Policy at Harvard Medical School. Most recently, Dr. Grabowski has been part of a National Nursing Home Commission to develop recommendations to assist care homes going forward as they deal with COVID-19. I spoke with Dr. Grabowski earlier, and here is our conversation.
Well, I'm here with Dr. David Grabowski, Professor of Healthcare Policy at the Department of Healthcare Policy at Harvard Medical School, and a frequent guest on CNN and other news outlets in the United States as an expert on long-term care. So, Dr. Grabowski, welcome to the BC Care Providers Virtual Conference. And I want to start off for our viewers just a little bit of an overview on the way that long-term care is provided and funded in the United States, because obviously there will be some differences between the US and the Canadian experience.
Absolutely. So first, great to be with everyone today. The U.S. Long-term care system has some really unique features. So the first, and this won't surprise anyone, it's incredibly fragmented. So each kind of setting is really paid for separately from all other settings. So every kind of provider on their own bottom. The government is the dominant payer of services in the US, largely through the Medicaid program. Medicaid is a state-based program here in the US. It's typically a lower reimbursement rate. And so many of our long-term care providers are actually under-resourced and underfunded. The other feature that's important is that many long-term care providers in the US, especially nursing homes and home health agencies, they care for long-stay, chronically ill individuals, but they also do short-term, post-acute, post-hospital care through the Medicare program. Medicare is a very generous payer, and so Medicare cross-subsidizes oftentimes the care of these longer stay, long-term care recipients. And so we have this really funny setup that we bundle basically post-hospital care and long-term care together in the same settings. And it's really that post-hospital care that's the engine for driving long-term care. The final point I'll make is that we have a largely for-profit industry. It's like, for example, the nursing home industry is 2/3 for-profit. Assisted living here in the US is almost 95% for-profit. So we have a lot of for-profit provision, very few nonprofits and very few government-run facilities.
And is there anything about that structure that exacerbated the COVID-19 situation? For instance, if you're doing post-acute care, was that a vector for the virus entering nursing homes in the United States?
Yeah, this is a great point. So it actually kind of magnified COVID in our nursing homes in several ways. First of all, many of the nursing homes here in the US were under-resourced pre-COVID, but following COVID, most hospitals stopped doing elective procedures. The only kind of patients coming from hospitals were COVID patients, and so many nursing homes and other long-term care settings weren't prepared to do that care safely. So they basically had all of the high revenue, short stay care dry up. That was non-existent, and they were left with just these long stayers. Many facilities did do that short stay care, and there was a lot of concerns, Terry, exactly as you're suggesting, that there was some discharge from the hospital bringing that into the nursing home, or nursing home residents, for example, going into the hospital for some other reason and picking up COVID and bringing it back. So this was a huge issue of just this kind of fragmentation and moving around and poor infection control that led to a huge growth in cases. I will say one of the biggest vector here in the States, however, was staff, kind of bringing it in from the community. The strongest predictor of whether or not a long-term care setting in the U.S. Had a COVID outbreak was whether there was COVID in the surrounding community. If COVID is present where the staff live, COVID was going to ultimately make it into that nursing home, because far too many of our long-term care providers lacked personal protective equipment, lacked testing, and really were unable to keep COVID out.
Well, that's a very good point. Thinking about bringing it in from community spread versus perhaps another long-term care facility or home where people were working here. We've incorporated a single site order. Can you talk about the the incidence of people working in more than one nursing home and how that played into the transmission of the virus?
So I'm really impressed by your single site rule. We did not implement that here in the States, and that was definitely found to be one of the vectors of individuals working across multiple facilities. And I'll actually give an example from some of our research. So we did this, other researchers have done this as well, but we use cell phone data to track where kind of individuals were going into different nursing homes within a market. And we found that a fair amount of the spread across facilities was due to staff moving from one facility to another, and we could tell they were staff based on the number of hours that the geolocation data through their phones was telling us they were there for 8 hours, for example, and we knew that they were working there rather than just delivering something or an EMT, an emergency technician on an ambulance run or something. These were staff. Staff definitely contributed to the spread across facilities.
And in the situation we have here at the moment, David, the community spread is increasing. We have the single site order, but people may now be bringing it from community rather than another nursing home. Is that a worry that even with a single site order, with spread in the community, now you may be only working in one nursing home, but you're in a community where there's more widespread transmission and you're bringing it in anyway?
Absolutely, that's a concern. The single site rule helps in terms of the cross facility transmission, but you're still at risk for having staff bring it in from the community. And there's really good data here in the US that it's really the community spread that's driving outbreaks within facilities. We have a student here at Harvard where I work. She did a great paper where she showed it's not just where the nursing home is located, it's actually where the staff live. And if the neighborhood where they live has less transportation, is more densely populated, it's these kind of factors that are going to lead to more cases, and ultimately that staff member, unbeknownst to them, bringing the virus into the facility. And so I think this asymptomatic transmission is what's really made COVID so challenging to contain in the US and obviously in Canada and elsewhere around the world. We can't simply take temperatures when staff arrive at work. It really requires adequate PPE to protect the staff and ultimately the residents, but also testing, cohorting, good policies and good pay for our staff. This is one of the really big challenges. I said earlier, Medicaid is the dominant payer here in the US. Because Medicaid's the payer, many of our direct caregivers here in the US make close to minimum wage. And if you can believe it, we've done some research just kind of determining the risk that these individuals are facing right now. And nursing home caregiver is actually the most dangerous job in America right now. So here we are paying these staff close to minimum wage, yet they're putting their lives on the line and risking obviously the welfare of their families and others to come in and care for older adults. I say this a lot, but I'll say it again today. Our direct caregivers are heroes. They deserve all the attention and credit they get, and they also deserve a living wage. And I hope that's something here in the U.S. that we can move towards going forward.
Yeah, I think that's a sentiment that's echoed here. The the virus has really laid bare who really is an essential worker in our society. So thanks for saying that. You talk about personal protective equipment, and you just participated on the Coronavirus Commission on Safety and Quality in Nursing Homes, and you talk a lot about PPE there. What went wrong? What went right in terms of PPE in the U.S. as it relates to nursing homes?
Yeah, testing and PPE have been issues from the beginning here. And I get testing is complicated for lots of reasons, but PPE, yes, we need to educate and guide nursing homes and how to use PPE safely, but we had far too many shortages here in the US. So we did a research paper last month that we published in the journal Health Affairs, where we found that 1 in 5 nursing homes in the US has a personal protective equipment shortage, a severe shortage. We need to do better than that. This is the best defense that we have in terms of protecting staff and ultimately protecting residents. We've tried several different measures here in the US. So let me first say we never nationalized the supply chain. That was a mistake. We should have done that from the beginning, and just the federal government should have owned this issue and sent PPE directly to every nursing home in the country. The federal government in several instances here has tried to ship a limited amount of PPE to nursing homes. Those efforts have been quite mixed in that the PPE has been delayed, and then oftentimes it hasn't been adequate. So, we had glorified trash bags that were supposed to be gowns being mailed to facilities. We had gowns without armholes. We had child-sized masks that were being shipped to facilities. So that was really an embarrassment here in the U.S. and completely inadequate. We need to provide high-level, high-grade PPE to every nursing home in the country here in the U.S. And I really believe, Terry, this is an issue the federal government needs to own in the U.S. and ship this out. And otherwise, we're going to continue to see this severe shortage that we recently documented.
Yeah, it's a real shame. I was health minister here in British Columbia when we dealt with the potential Ebola crisis, and PPE was a big issue. And it seems like a lot of that PPE that was in inventory got stale dated and thrown away and not replaced, which is, in hindsight, a real tragedy. David, I want to talk now about something that's really important to many families of people in care, and that's the visitation policies. Obviously, we've had to really clamp down. Can you talk about the impact that's had on nursing home residents and families, and what we can do to bring families back together in a safe way?
Absolutely. I'm so glad you raised this. This is the number one issue I hear on social media, get emails about when I'm giving congressional testimony. These have been the kind of the most gripping moments, is just hearing the experiences of family members. So we know that COVID kills older adults, and we've seen tens of thousands of deaths here in the US. I also think it's safe to say that isolation and loneliness kill older adults. And that's exactly what we've done, going on month 7 now of really limiting visitation in nursing homes. And I will completely acknowledge, early on, I was very much on board with closing nursing homes and protecting older adults, but that was a short-term measure, and that was never supposed to be the long-run solution here. And so we really need to figure out ways to get families back into nursing homes. I wrote another Washington Post op-ed with a couple of colleagues where we thought about essential care partners, that family members could actually be a part of the care team. And they're so important for the health of these residents. And in order to safely introduce them back into facilities, we need obviously personal protective equipment and testing and good protocols in place. I think we can do that and very quickly. And I will say the federal government here in the US just yesterday, sort of corresponding to the release of the commission report, announced that there'll be new visitation rules, and they're beginning to move towards opening up nursing homes. So that's a really a step in the right direction. But nobody's saying we can open up every nursing home tomorrow and just throw the doors open and not do this in a safe and nuanced way. This is it's going to take a thoughtful approach, but this is doable, and we can certainly use these resources to reconnect family members with their loved ones. Because otherwise, I hear a lot from residents and family that I'd rather be dead than not get to see my family, and I really believe that's true. That at some point this pendulum that was over on the safety side has swung too far. We need to bring it back towards resident quality of life and resident dignity.
That's such great points that you make there. Let's finish off, David, talking about, as we enter flu season here in North America, what can we do to protect nursing home residents going into winter?
First and foremost, we can all get our flu shots. So let's do that. Second, we're gonna inevitably face some surges again in terms of outbreaks, and we're starting to see that here in the Midwest in the U.S. And I'm really worried here about the Northeast where I live in the U.S. And I'm certain there'll be other hotspots around the country. And so, how do we put kind of a good system in place? Can we finally learn lessons that I don't think we've incorporated here in the U.S. yet? We didn't, as I like to say, learn the lessons of Asia or Europe. We failed to ignore the early lessons from Kirkland, Washington, here in the U.S., the Northeast where I lived, and the Sun Belt states, the Midwest. Let's finally begin to put those good protocols in place. And Terry, you mentioned the commission report that I was a part of that was just delivered to the federal government and was released yesterday. Some of my fellow commissioner members were at the White House yesterday to help with the release of the report. And I really think that report gives us a roadmap here in the U.S. We touched on 10 themes. It's like 10 areas, many of which we've been talking about: testing and PPE and cohorting, support for workforce and data, and every all of the points that you could imagine. Those 10 key themes feed into 27 recommendations, and those 27 recommendations feed into over 100 action steps. I know that sounds like a lot, but these are all steps that could be taken over the coming weeks and months that could really put the U.S. and I think other countries that wanted to follow this roadmap in a really good place to protect nursing home residents and their caregivers. So by no means do I think it's too late, even though we have this flu season coming, and a lot of us are nervous. We do have a roadmap here that could really protect a lot of our most vulnerable individuals in long-term care settings. But I always go back to this, and as a former health minister, Terry, you can appreciate this. It's a matter of political will. And are we finally here in the U.S. going to prioritize nursing home residents and their caregivers? And unfortunately, I think we've seen a lot of ageism, a lot of sexism and classism when it comes to their caregivers. Are we finally willing to make that investment to protect these residents and also their caregivers? And that's the key question, because I think we know how to do it. It's a matter of will.
Well, Dr. Grabowski, thank you very much for joining us today, and thanks for all you're doing to protect the health and safety of families, residents, and the people who care for them. Thank you very much.
Thanks so much, Terry.
Our final speaker, looking at the international response to COVID-19 on long-term care, is Lee Fei Loh, an associate professor in aging and health at the University of Sydney in Australia. Dr. Loh, welcome to the BC Care Providers virtual conference, and perhaps as an introduction, you can tell our viewers a little bit about the way that the structure and delivery and funding of long-term care in Australia, so that we have some context vis-a-vis Canada.
Thank you for having me. Australian aged care is funded, administered and regulated by our federal government, so our national government. It funds care for people living at home as well as nursing home or residential aged care. The services are actually tendered out, so they're delivered by a mixture of not-for-profit, for-profit, and state government and local council providers. There's a user contribution to care, so people pay something for care, but this differs depending on what type of care you're getting. And those are means tested. And I guess it's useful to contrast that our healthcare is run by our state government, so they're quite different silos of funding and administration.
Well, that's very interesting because we're having that debate here in Canada, how much the federal government should get involved in the delivery of aged care here. Now, if we go back to mid-June and look at the COVID impact in Australia versus Canada, we had thousands of unfortunate deaths in long-term care here, and I think only about 30 in Australia. What do you attribute that tremendous success in protecting seniors in Australia, at least in the first wave?
So I think what's important is that we had relatively little community transmission in the first wave. So about a third of COVID cases were community transmission, and were people who got put in hotel quarantine here. We only had 2 big nursing home clusters in the first wave. One, I think, that was the first death, Australian death, COVID death, and that home worked very closely with state health to manage that outbreak. The second outbreak, Newmarch House, they did much better. They decided they were going to palliate in the nursing home, and we should have learned a lot of lessons from that. But I think that from the other 15 nursing homes, we know there were cases, mostly staff cases. It was a combination of good luck and rapid collaboration with local healthcare teams, most of them in New South Wales, that prevented spread.
And did you have a situation where workers were working at different sites, or in Australia, are people limited to one site?
Yeah, so it's very common that workers work across multiple sites, not just personal care assistants or nurses, but also physiotherapists or the hairdresser, the cleaning staff, the laundry staff. It's super common. Our government put out a package quite early on. I think by May they announced packages of funding and policy changes, including trying to limit people working between sites. But what we discovered when we talk about the second wave is that we hadn't really implemented those policies or spent that money very well.
So now we are seeing a bit of a second wave in Australia, particularly I think in Melbourne. Can you talk about why that is an issue at the moment? Is there anything that's changed, or things, as you say, perhaps weren't followed through as much as they should have been?
So our second wave happened in Melbourne because of breaches in hotel quarantine. And we know that about 99% of all the cases in Victoria can be linked through genomic sequencing to 2 hotels, where they think, security guards weren't practicing proper PPE or infection control, and then they took it home to their households and families. So by the time health authorities realized that we had significant community transmission, there was already a lot of spread, and that's when Melbourne got put into full lockdown, including nightly curfews at the moment still. So the spread in nursing homes, I believe we have, lots of nursing homes with spread, with large numbers of cases. And let me go back and say the Melbourne outbreak's been confined to that geography of Melbourne because our state borders are closed, which is, it seems to be quite a unique thing to Australia. Many of the borders got closed in the first wave and never got reopened. But even between New South Wales, which is where Sydney is, and Melbourne, which is a big trade route, that border's been closed as well. So basically, Melbourne's isolated and people can't get in or out. So that's how they've contained that spread to Melbourne. We know in Melbourne that there's at least 50 care homes where one resident has died with COVID. And in the worst, 20 care homes, like there've been over 2,000 infections. So we didn't learn from the two outbreaks in Sydney, and there's been a aged care Royal Commission here, which included looking at why we weren't ready, and it's clear that there were guidelines but not a plan, that nursing homes weren't really supported to get ready, that they weren't ready to lose 80 to 100% of their staff if there was an outbreak in their facility, that they didn't have access to PPE and staff didn't know how to use PPE, and staff were still working across multiple facilities.
So it sounds like really Australia was lucky in the first wave, and then some of the weaknesses we've seen elsewhere really came into play in the second wave. You mentioned the Royal Commission, because that started, the Royal Commission on Aged Care started before the pandemic. Are there any findings there that you can relate to our viewers in terms of things Australia is looking at to improve aged care in your country?
The first report from the Royal Commission was called Neglect. It was really saying that we've not looked after our elders properly, and there's marked deficiencies in the system, and the system is uncaring. So not about individual people, individual carers or facilities, but that the system doesn't look after people. I think that the recommendations will be around workforce, definitely. So our aged care workforce is not just underpaid, but there's not enough clinical. The clinical people have come out of it more and more. So, for instance, a debate here is about nursing and nursing to resident ratios, and we don't have them in most places in Australia. A second point the Royal Commission's been looking at is about financing. So, is there enough money? And probably there isn't. And how do we as a country afford that, and who contributes and how much? And the third point, I guess, we talked about already, which is the interface between healthcare and aged care, and how we don't do that very well, and we need to do that better.
It sounds like many of the same things that we're hearing about the system in Canada apply to Australia. And the human resource challenges sound like, those are challenges in both countries. Can you think of ways in which we can attract people into aged care to make it a career of choice for people? Any thought that's being given to that in Australia?
It feels like there's two isms, that make it unattractive. First, it's women's work, so it's undervalued and underpaid. And then it's work with older people who are undervalued. So, everyone wants to work with kids, and our childcare workers get paid substantially more and are more qualified. So it feels like the whole system needs a marketing. Isn't it terrible to say? We need to remarket the whole thing, as well as having pathways, I guess, for jobs. Our workforce is increasingly part-time and casualized. So again, that makes it difficult to see it as an attractive kind of career, as opposed to a job that you do while you have kids or while you're at uni or something else like that.
Well, it sounds like the challenges in Australia are very similar to those we're facing here in Canada. But Dr. Lowe, I want to thank you very much for your insights today, and wish you and all Australians the very best of luck as we deal with COVID-19 heading into your summer and into our winter. Thank you.
Thanks, Terry.
Once again, I'd like to thank our experts for today's important session titled Seniors Care and the COVID-19 Pandemic, How the International Community Has Responded, where we looked at some of the international experiences of COVID-19 and its effects on seniors' care, including from Canadian expert Dr. Samir Sinha, as well as experts around the world such as Dr. David Grabowski from the United States and Professor Li-Fei Lo from Australia. I'd also again like to thank our sponsor for this session, Essity. Overall, this is an important discussion, particularly as we look at best practices internationally. And tomorrow, we'll also be continuing this discussion as part of a Canadian panel with various experts across Canada, to be moderated by Michael Nyssen, Executive Director for the National Institute of Aging at Ryerson University, where various topics will be discussed, and they will include the role of the federal government and organizations such as the Canadian Association for Long-Term Care in dealing with COVID-19, how we can better prepare for a potential second or future waves, the role of the private sector, health human resource challenges facing the sector, and the future of long-term care and seniors' care. Likewise, on Friday, we will have a panel discussion looking more at the British Columbia experience with experts from across the province, which will be moderated by my colleague Mike Klassen from the BC Care Providers Association. Finally, I would like to remind those watching that after a short break at 1 p.m., we will have a workshop session entitled The Race for a COVID-19 Vaccine, where Dr. Dion Neem from Sanofi Pasteur will showcase the novel coronavirus, the race for a vaccine, and take attendees on a journey from past, present, and future to explore how the swift response in BC directly mitigated the devastation that COVID-19 has caused in other jurisdictions. Thank you for watching, and I hope you enjoy the rest of the BC Care Providers Association virtual conference.